You stay here. Stay here only. I can't go and call you.
Good evening, doctors. Welcome to Shield Connect platform. So today we have Dr. Sangeeta Singhal. Ma'am is a senior consultant gynecologist in Singhal Clinic, Jamshedpur, Jharkhand. And ma'am also worked as ex-HOD obstetric gynecologist, in Tata Main Hospital, Jamshedpur. And also ma'am is a past president of Jamshedpur Obstetric Gynecology Society and ISO PAD Jamshedpur Society. And we are very much happy to have you here, ma'am, this evening. So ma'am will be taking the session on GDM and recent developments in GDM. Ma'am, the session is live. Now you can take over the session, ma'am. Thank you.
Thank you so much. And good evening, everyone. Today, I'm going to talk on the recent developments in gestational diabetes mellitus. As we all know that the prevalence of diabetes is increasing so much all over the world, and especially in our country, probably because of the population aging, probably the lifestyle changes, and probably the increasing rate of obesity in our population. And so that is the reason that even gestational diabetes is also increasing because of the same reason. So why we are talking about gestational diabetes? Because if it remains undiagnosed or inadequately treated, it can lead to significant maternal and fetal complications. And women with gestational diabetes mellitus and their offsprings are at increased risk of developing type 2 diabetes in their later life. So how do we diagnose this gestational diabetes? Well, this is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first recognition during pregnancy. So GDM, it's defined in this way. It includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. So the FIGO recommends the term hyperglycemia in pregnancy, whether the diabetes is diagnosed before pregnancy, it is diagnosed during pregnancy, or it is there because of the pregnancy. So why is diabetes important? As we said, because women with gestational diabetes are at increased risk of developing type 2 diabetes in their future life. And in fact, as high as 50% of these women who had gestational diabetes are likely to develop type 2 diabetes in their later life. And the second part is that children, they are at a higher risk of developing diabetes, and even their subsequent generations are going to have increased incidence of diabetes because probably there is a fetal programming in the mother's womb, and which programs these children to develop higher incidence of diabetes and even in their subsequent generation. So as we talk that as the incidence of diabetes is already very high, this is if we are not going to diagnose and treat diabetes at this stage during pregnancy, we are going to have more and more cases of future diabetics in our population. So what are the major consequences of gestational diabetes in the mother and their offsprings? In the mother, I will start right from the pre-pregnancy sugar. If the pre-pregnancy sugar is very high, the chances of developing congenital abnormalities in the offspring is very, very high. And there is increased risk of miscarriages in the early pregnancy. There is always an unexplained intrauterine death during pregnancy. And there is a very high risk of preeclampsia, as high as 10 to 20% of women with GDM are going to develop preeclampsia. In diabetes, there is, because of the high blood sugar, there is a increased blood sugar in the fetus, which causes macrosomia in the babies. And because of this increased fat mass and macrosomia in the baby, there is increased risk of operative delivery and labor complications during delivery. And there is increased chances of cesarean section during delivery. And because in the diabetic women, we do not allow them to go post-date, there is increased incidence of induction of labor. In the postpartum and beyond, as we said, there can be a recurrent gestational diabetes in the next pregnancy and development of type 2 diabetes in this pregnancy later on. And in the offspring, as we said, that because of the high blood sugar milieu in the baby at the time of developmental stage, there is increased incidence of congenital abnormalities in these babies. And as high as about 6 to 8%, and even it can be higher if the sugar is very high at this chances of organogenesis. And the defect can be central nervous system defect, it can be cardiac defect, it can be spinal defect, especially the sacral agenesis is very common, and it's one of the significant malformation due to diabetes. And as we said, the fetal programming, which causes increased incidence of diabetes in these babies, and macrosomia and large for gestational age babies, leading to all kind of complications to the baby as well as to the mother during delivery. The neonatal complications, these babies are, the chances of prematurity is high. Because of this macrosomia large for gestational age babies, there is a poor hyaline membrane development, and that leads to increased chances of respiratory distress. There is increased chances of perinatal asphyxia. The metabolic complications, especially hypoglycemia and hypocalcemia, is quite common, and polycythemia and hyperviscosity, the low iron reserve, and hyperbilirubinemia is quite common in the neonates soon after birth. And even there can be cardiomyopathy. And the long-term outcome in the offsprings can be obesity, there can be development of type 1 diabetes, or there can be type 2 diabetes or metabolic syndrome. So overall, if we see, it can cause jaundice to the babies, it can lead to birth injuries, it can cause temporary breathing problem because of respiratory distress, and it can lead to low blood sugar because of hypoglycemia, which can occur because soon after birth, these babies are cut off from the sugar which is there from the mother, and so there can be low blood sugar in these babies. So what are the facts and statistics of gestational diabetes? About 4 million women are affected by GDM in India at any given point of time. And if diabetes is poorly controlled, the infant has about 10% chance of being born with a defect. But the good point is that 75% of gestational diabetics can be well treated with healthy diet and exercise alone. And only 5 to 10% of women have problems with diabetes after they deliver. Then the prevalence, I mean, depending upon the different part of our country, it is quite high in Punjab and also in the down south. So what is the pathophysiology? The basic pathophysiology for gestational diabetes is hyperglycemia, there is insulin resistance, there's increased insulin secretion, there's further beta cell hyperplasia because pancreas is trying to secrete more and more insulin to overcome the insulin resistance. And there's high blood sugar, and this happens because of the presence of placental growth hormone and human placental lactogen, the hormones of pregnancy, the progesterone. These all causes increased insulin resistance, and there is hyperglycemia, which leads to high blood sugar in the mother, as well as this high blood sugar which goes to the fetus, crosses the placenta, and that initiates the fetal pancreatic insulin, and there is a further increase in the fetal insulin, and which causes increased growth of the baby and macrosomia. So the basic pathophysiology, as I said, it is the insulin resistance due to hormones by placenta, like human placental lactogen, human placental growth hormone, progesterone, as well as there is increased calorie intake and reduced exercises, and sometimes can be genetic, which we do not know. And this insulin resistance increases as pregnancy progresses. So it's the same thing what we talked about, this Pedersen hypothesis. When the more and more sugar goes to the baby from the mother, there is further increase of the stimulation of the fetal pancreatic cells, which increases further insulin, which causes further macrosomia of the baby, and there is increased blood sugar in the baby, and which leads to obesity and diabetes in later life. So now we know that these are the problems which can occur. So how do we screen these women to detect the gestational diabetes at the earliest? So do we do selective screening or do we do universal screening? Well, universal screening for GDM, it detects more cases and improves maternal and offspring prognosis. So every woman should be screened, especially in our country, because we fall in the ethnic group, which forms as one of the risk factor for GDM, though the other risk factors for GDM are the previous history of GDM, previous history of, or the family history of diabetes, the previous macrosomic baby of weight more than 4 kg, the previous unexplained stillbirths, previous neonatal hypoglycemia, hypocalcemia, or hyperbilirubinemia. Apart from that, advanced maternal age, obesity, polyhydramnios, suspected macrosomia, bad obstetric history, and very important, the polycystic ovarian disease, they all form the risk factor. But the most important for we Indians, our ethnicity is such that we form one of the risk factor. And so for our women, every woman should be screened, and it should be screened at the first antenatal visit. And in Indian women, there's a 11-fold increase in the risk of developing gestational diabetes during pregnancy as compared to other Caucasian women. So the preferable thing is to screen all antenatal women at their first antenatal visit to detect undiagnosed type 2 diabetes, as well as if there is any high blood sugar, which can be detected at that time. And the recent trend is to check hemoglobin A1C in the first trimester itself to diagnose overt diabetes mellitus. And if hemoglobin A1C is more than 5.9%, it's high risk of GDM, and screen them later on. And if hemoglobin A1C is more than 6.5%, then they are definitely type 2 diabetes, which is already there, which are being diagnosed now. So these are the common guidelines for gestational diabetes, like WHO, International Association of Diabetes in Pregnancy Study Group, the American College of Obs and Gynecology, and WHO. And there are many other groups who have done lots of studies, and they've did this glucose challenges either with the 75-gram glucose or 100-gram glucose with the different level of fasting, either more than 92, 95, or sometimes WHO says 92 to 125, with a 2-hour postprandial of more than 140, 153, 155. But again, it varies with the different study group, and we also have to deal with it accordingly. So, but the most important guideline which we all Indians we follow is the Indian guideline, that is a DIPSI guideline, where it is a random test which is done with a 75 oral glucose challenge test, and after 2 hours the blood test is done, and if the blood sugar is more than 140 milligram, it is a diagnostic of gestational diabetes. There are different American colleges and other nice guideline, and others, they have done either single step, where it was a O'Sullivan method when they were doing the 50-gram glucose, and those who were screen positive, they needed a further second step study check by 100-gram glucose GTT, where it was the 3 studies, the fasting 1 hour, 2 hour, and 3 hour study, which was quite cumbersome, but they are still following. But in India, we are following our DIPSI guideline, which is easy to do it. And for the women also, it's easy. And even for the clinician, it is easy to detect. And we are able to detect more and more cases of gestational diabetes. So the first visit is done at the first visit. We are doing this screening test and diagnostic test. But many times when you are giving at the first visit, if it is in the first trimester, because they are having nausea and vomiting, and if you give 75-gram glucose, then chances of vomiting is very high. So even the fasting blood sugar is being done at the first visit, and if it is less than 92, they are not GDM, and repeat this oral GTT with 75-gram glucose at 24 to 28 weeks of gestation. But if the fasting level is between 92 to 125 milligram, then probably we are dealing with GDM. And if it is more than 126 fasting and hemoglobin A1C more than 6.5%, then mostly it's an over diabetes. So the protocol should be test at the first visit and repeat oral glucose challenge test at 24 to 28 weeks, which is the time of pregnancy when there is a maximum diabetogenic effect because of the human, the level of this human placental lactogen and placental growth hormone as maximum. And so it should be repeated at that time, because many times you may not detect in the first visit, but it can be detected later on. And so it should be repeated definitely. So how do we manage? What are the management issues? One, the important is patient education, which is the very, very important, and the medical nutrition therapy, which is the cornerstone for the treatment of these gestational diabetes. Those who do not respond to medical nutrition therapy, the pharmacological therapy has to be given, and the glycemic monitoring to be done by SMBG and maintain a target. The fetal monitoring either by ultrasonography, and the clinical monitoring should be done, and the planning for delivery has to be done accordingly. So the diet and exercise is very important with glucose monitoring, and those who do not respond from pharmacological therapy has to be done. And the goal of therapy is to achieve normoglycemia, prevent ketosis, provide adequate weight gain, and contribute to fetal well-being. So the healthy lifestyle is the most important. Do some exercise, do a proper diet, eat right carbohydrate, eat healthy breakfast, opt for a sugar-free diet, sleep well, monitor blood sugar level regularly, and take the prescribed medicine as directed by the physician. So management of pregnant women with gestational diabetes is the medical nutrition therapy should be started with physical exercise, wait for 1 to 2 weeks, depending upon the gestational age, and repeat the blood sugar, both fasting and postprandial. And if the postprandial is less than 120 and fasting is less than 95, continue diet and exercise and monitor the blood sugar level accordingly. But those who have got more than 120 postprandial and fasting more than 95, start them on oral anti-diabetic along with the diet control. And if they do not respond with even with the oral anti-diabetic, insulin should be started. However, for the management of diabetes, insulin is the gold standard, but now more and more people are using oral anti-diabetics because of the safety is much better and much easier to continue with the oral, and even the patient compliance is much better with the oral anti-diabetics. So for the diet, a typical meal plan, the 3 small to moderate size meals and 2 to 4 snacks with a carbohydrate about 40% of the total calories, and 20% should come from protein and 40% from fat, which has to be less saturated fats. And the calorie requirement should be depending upon the pregnant women's weight. And the ideal, if it is the ideal body weight, it should be 30 calories per kg per day. And the overweight, 25 to 25, 20 to 22 to 25 kilocalories per kg per day. And the morbidly obese women should be 12 to 14 kilocalories per kg per day. And the underweight should be 40 kilocalories per kg per day. And for the monitoring of glucose, normally we do, ideally it should be done 4 times a day with 1 fasting and 3 postprandial, that is 2 hours after each major meal. And the target of blood sugar, as I said, fasting should be less than 195 and postprandial should be less than 120. Though it is difficult practically to have 4 blood sugar test every time, but it can be once the sugar is controlled on a particular level of diet or the pharmacotherapy or the medical treatment, then one can control it with fasting and postprandial blood sugar. Well, glucose monitoring with glycosylated hemoglobin, basically it is useful to detect overt diabetes in early pregnancy, but it is too crude to guide insulin adjustment with hemoglobin A1C. But when diet management is inadequate, insulin, which I said is the gold standard, but oral anti-diabetic drugs are being started after the diet management is inadequate. And if oral anti-diabetic drugs are also not able to control, then insulin should be started. For the insulin, the human insulin has to be given either it's in the regular insulin form or it is a pre-mixed where it is a mixture of short acting and intermediate acting insulin, which is the best insulin which we are using for the management of diabetes. But the short acting analogs like insulin Lispro and insulin Aspart can also be used, and the long acting analogs like insulin Detamir, which is again a class B drug, can be used. But the best is the pre-mixed insulin, which we have been using right from the very beginning, and we are still continuing. And the usual requirement is about 0.5 to 0.7 units per kg, and it can be increased depending upon the gestation and depending upon the blood sugar level. And as I said, it should be intervention either with insulin or oral drug should be if patient do not respond to diet control within 1 to 2 weeks. And the most effective period to reduce macrosomia incidence is from 24 to 33 weeks. And so insulin is essential or to prevent macrosomia. And insulin should be started with simple regime, increase the complexity as needed. Hospitalization is not mandatory, but sometimes it may be necessary if the sugar is very uncontrolled and there is a sudden fall in blood sugar. So in those cases, you need to hospitalize this woman to control their blood sugar level. Amongst the oral anti-diabetics, metformin has been safe. Safety has been established, especially in the PCOS pregnancies. And so it is being continued even for the gestational diabetes. It crosses placenta. The levels may be higher in the fetus. The long-term follow-up has not been done, but several studies which has come and they have found that metformin has been quite safe for the management of diabetes. The other anti-diabetic are glyburide, which is recently the use has been increasing, and it is generally well tolerated, no fetal hypoglycemia. But again, the long-term follow-up studies are still not too much available, and it needs several studies which have shown that the glibenclamide and metformin have been effective for the management of gestational diabetes. Many studies which has come up, but still we need more and more studies of these oral anti-diabetic drugs for the management of gestational diabetes. But the new drug which has come up, that is emerging role of myoinositol in gestational diabetes. Here again, the myoinositol and D-chiroinositol, these are the most important member of this inositol family, and they basically regulates insulin signaling, and basically they are insulin sensitizer and helps in reducing the insulin resistance and thereby reducing the helping in gestational diabetes. So, lots of studies which are coming as the role of inositol for the supplementation in prevention of gestational diabetes mellitus, but still we need more and more studies to confirm its use, and it should come in the textbook for the management of gestational diabetes. So I think we still have to go a long way for the confirming this, but yeah, this it helps in prevention of gestational diabetes. So during pregnancy we talked, but what about the intrapartum glycemic management? It's very important that one has to withhold the morning dose of insulin, and if induction of labor or cesarean delivery has been planned, it should be done in the morning, early in the day. Start 5% dextrose infusion start a separate regular insulin infusion depending upon the blood sugar level, and hourly blood glucose measurement has to be done, and adjust insulin as per the blood glucose level and maintain the blood sugar between 80 to 110 milligram per deciliter. Peripartum, yes, you have to avoid maternal hypoglycemia during labor to reduce fetal acidosis, neonatal asphyxia, and neonatal hypoglycemia. Post-delivery follow-up is, as we said, it's important because these women should be advised or should be counseled about that they are likelihood to develop type 2 diabetes in the future, and they should take care of their diet and exercise. And normally blood sugar level usually returns to normal after delivery, but after 6 weeks they should do a blood sugar test to confirm whether their blood sugar has come back to normal or it's still high, and their offsprings are at an increased risk of developing type 2 diabetes, and so all this they should be counseled about a healthy lifestyle and healthy lifestyle behavior, particularly about the role of diet and exercise. So to take home message, I'll say that gestational diabetes mellitus, it can be easily controlled by diet and exercise. Only in few women in whom blood sugar is not controlled by diet and exercise, oral anti-diabetic, especially metformin or insulin injections may be required. Gestational diabetes mellitus can be treated with oral metformin tablets as they do not harm the fetus, and insulin will be stopped in most of the cases after delivery. Injecting insulin over abdomen is 100% safe because lots of women, they feel that the baby is there, how can we give insulin in the abdomen? But it has to begin subcutaneously, and it is quite safe to put it in the abdomen. Modification of diet is very easy. Sweets should be avoided at all times during pregnancy, though it becomes very difficult in our country. But if the blood sugar is controlled, patient and her baby both are safe and healthy. And pregnant women with GDM should deliver at health facilities because it will help in the management of any complications which can be encountered during delivery, either to the mother or to the baby. Thank you so much for patient hearing. Thank you so much.
Stop sharing the whole.
Hello, can you hear me?
Participant कितना? दो ही?
Really?
Two participant.
हेलो, ये म्यूट किया हुआ है.
फोन करके पूछो. म्यूट पे क्यों? ये तुम्हारा दो ही है.
What is this query? The role of nutrition in diabetes. Well, as I said, the nutrition is very, very important for the management of diabetes, especially as I said that it reduces the sugar level, if we reduce the total calorie intake, the sugar level, blood sugar level reduces, and it treats the gestational diabetes. And so medical nutrition therapy and exercise is very, very important for the management of gestational diabetes. Yeah, as I said, that the myo-inositol has been one of the important thing which is coming up for the treatment of gestational diabetes, but uh, still it is in the experimental level, though the method or the mode of action is as insulin sensitizer, and it helps in reducing the blood sugar level. So it is helpful in treating gestational diabetes, but more and more research is needed before it becomes kind of a textbook part. It becomes a textbook part for the management of gestational diabetes. But yes, now the role of myo-inositol is coming up for the management of gestational diabetes.
Hello. Ma'am, am I audible, ma'am?
Yeah, yes.
Sorry, there is a small technical glitch. Yeah. Ma'am, those are the two queries actually I received from delegates. So there are no further queries.
Yeah.
And once again, thank you so much, ma'am, for spending your valuable time with us in this evening and sharing such a great knowledge, which is very much useful for the patients and, of course, the participants who actually participated through Delegate Link. And sitting here, we are also got so much enriched with your vast knowledge, ma'am.
Thank you so much. Thank
Yeah.
you so much.
Yeah, and we look forward to have more and more webinars like this with you, ma'am.
Thank you. Definitely. Anytime we are there. Thank you so much.
Pleasure
Yes.
meeting you, ma'am. Thank you so much.
Thank you so much. So I can leave now, huh?
Yes, ma'am. Yes, ma'am.
Thank you so much.
Thank you.